Tayo, you're muted, I think.
Yes, I was very muted. Hello, everyone. Good morning.
There's some nice background music. I'm not sure who that is, sorry.
Yes, that's intentional. Thank you very much. Good afternoon, good morning, good evening from wherever you're joining from. Thank you very much for your time and for coming on to OAU Med Talks, the EDGE series, today, 13th August 2023. And today is a very special episode because today we have the first global edition of OAU Med Talks, and we have gotten to contemporary practicing physicians who are well versed in the field of pediatrics across the globe. On this forum today, we have Dr. A.G. Faniku, who is a pediatric hospitalist in Advent Health, Texas in the US. We have Dr. J.O. Onobakpeya, who is a consultant pediatrician and focal person for adolescent HIV care at FMC Benue State, Nigeria. We have Dr. A.A. Ogundiya, who is a consultant pediatrician and clinical lead for the neonatal unit at St. Mary's Hospital, Isle of Wight in the United Kingdom. And today for this Global Pediatric Summit, they will be speaking to us about the regional approaches to managing asthma in pediatrics. So we will start this episode by having Dr. J.O. Onobakpeya speak to us on management of pediatrics from the Nigerian perspective. We are also going to have Dr. Ogundiya obviously speak from the United Kingdom management perspective. We will have Dr. Faniku also speak today, and we are very mindful of time, so please bear with us. We will have questions at the end of this forum. So please reserve your questions. If you have any questions, you can put them in the chat in the meantime, and then we can get to them towards the end. Just make sure you write it down and let us know. So without further ado, I would like to introduce Dr. J.O. Onobakpeya, MBCHB, FWACP Pediatrics, is a consultant pediatrician and the focal person for adolescent HIV care at the Federal Medical Center, Makurdi, Benue State, Nigeria. She graduated from the prestigious University of Ife, which is now known as the Obafemi Awolowo University, Ile-Ife, in 2005. Dr. Onobakpeya had her residency training at the Lagos University Teaching Hospital, where she also served as the chief resident. She attended some certificate courses and graduated with a postgraduate certificate FWACP in 2018. She proceeded to FMC Makurdi, located in Benue State, to work as a consultant pediatrician with special interest in nephrology. Currently, she's the team lead of the Antimicrobial Stewardship Program and the supervisor of the Adolescent OTZ Club for adolescents living with HIV. She's happily married with children. She loves God and enjoys watching movies in her spare time. Please welcome with me to this stage, Dr. Joy Onobakpeya.
Hello, good evening all. Good evening all. So I'm Joy, and I'll be talking about regional approaches to managing asthma in pediatrics, Nigeria perspective. Next slide. So we'll run through this presentation. Using the outline that you can see on my screen. So what do we want to achieve at the end of this presentation? We really want to be able to identify and classify asthma in children. We also want to know the risk factors for exacerbation and discuss the management across the globe. So would want to introduce asthma by understanding the fact that it is a multifactorial chronic inflammatory disease of the airways. It's got wider variation of possible mimics when you compare it to adults, and it can present as flare-ups that we call exacerbation. Also, it can present as a chronic disease that requires long-term management. So what's asthma? According to the Global Initiative for Asthma, which is abbreviated as GINA, it's a heterogeneous disease that is characterized by chronic airway inflammation. This makes the airway sensitive to several things that we call the triggers. There is an increase in the global prevalence of childhood asthma, and with substantial global variations in the prevalence of symptoms across countries. In Nigeria, the prevalence ranges from about 5.1 to 14.3%, with Lagos having the highest prevalence and Ilorin the lowest prevalence. Asthma is a potentially life-limiting condition which can lead to many school missed days, acute presentation in our emergency departments, and then hospital admission as well as death. Next slide. So what are the risk factors for this presentation? The risk factors cuts across the globe, but in Nigeria, what's peculiar to us, we know that we have environmental factors coming and taking the lead, where you have air pollution from rapid urbanization and industrialization, like you see in Lagos, increasing the prevalence of asthma. So atopy, genetic factors, family history, and overweight, obesity have also been linked to asthma. How does this come about? That's the pathophysiology. Like you can see in this diagram here, in this figure here, you can see that there's a normal airway, which is quite spacious. The lumen is spacious. And then you see the asthma airway, which is narrowed. So basically, with the presence of triggers, you have inflammatory cells running into the airway, and then they trigger this inflammatory response, leading to hypersecretion of mucus by the goblet cells, and also swelling of the bronchial membranes, which we call edema, and also airway muscle constriction, and this leads to narrowing. So classification. So basically what I just explained is the slide that has just come up now. So in classifying asthma, for you to be able to manage asthma effectively as a doctor and as a pediatrician, especially in children, you need to classify it, because it is the classification that is going to aid your management of asthma. So asthma is basically classified broadly into two classifications, where you have the acute exacerbations, where you have mild, moderate, severe, and life-threatening, and the chronic stable state, where you classify as either intermittent or persistent, and the persistent is further classified as mild, moderate, or severe. So as when we're discussing the management, we'll be able to use them to see how we manage our cases here. So what are the presentation? How does a child with asthma present? Unfortunately, in Nigeria, which you don't see outside the country, in the UK and in the US, is most of our patients come to us with acute exacerbations. The first time you are diagnosing an asthmatic child is most likely when he comes in with a moderate or a severe acute exacerbation of the asthma. But by and large, basically the symptoms are frequent cough, the wheezing, the chest tightness, and then the shortness of breath, then the exacerbation symptoms, which we're going to see soon. So how do we make diagnosis? So diagnosis is another challenge that we have in Nigeria and developing country. Now, basically, for you to diagnose asthma in children, there's a challenge of you not being able to make an accurate diagnosis for a child who is less than 5, and this cuts across globe. However, for us here in Nigeria and in developing countries, we also have some limitation with logistics and availability of materials to work with. So, but for you to make diagnosis of asthma, first of all, the symptoms I listed above would be there. And then we make use of the spirometry and the peak flow meter, that's the peak expiratory flow rate, to make this diagnosis. The spirometry basically helps us to measure the airway limitation, and also it helps in reversibility testing. What do I mean by airflow limitation? Airflow limitation, like we see that the airways are narrowed, so there's flow limitation. So when you use the spirometry to measure the FEV1, which is the first expiratory volume in the first minute, and the first vital capacity in the first minute. So you get a ratio, and you get a ratio of 0.9, with less than 0.9. That's indicative of asthma. Also, for the reversibility, if you administer 4 to 10 puffs, depending 4 puffs of the short-acting beta agonist, basically known as the salbutamol, if you administer it and measure the FEV1 before and after, there's an increase of above 12%, is indicative of asthma. What other ways can you diagnose asthma? You can use the peak expiratory flow meter. That's the peak expiratory flow rate can be measured, and this measures the reversibility, the same mechanism as the reversibility in spirometry, where after SABA, you get an improvement in the flow rate. Exercise challenge can also be used, and then other testing like ATOB testing can also be done. So first of all, you suspect with the symptoms, and you go ahead and do the spirometry or the peak expiratory flow rate. And this is possible only in children that are above 5 years. What do you want to achieve when you want to manage? As the goals of management, next slide, you want to achieve good symptom control. You want to be able to relieve symptoms when they come around. You want to minimize exacerbations, and then also minimize persistent airflow limitation, and also ensure that you have minimal side effects. So having this goal at the back of your mind, a child comes to you in the emergency room, and most times we have them present either as moderate or severe exacerbations. I always And we advocate the use of this chart that you can see. This chart gives you some parameters, which are the findings, the mental state of the child, the oxygen saturation, presence of cyanosis. Majority of these things, we can do them in Nigeria here and in developing countries. So I basically make use of about 4 of them. What I do is okay, the child comes in, I assess immediately. Is this child mild, moderate, severe, or is he having a life-threatening exacerbation? What's the pulse oximetry reading? What's the SpO2? What's the heart rate? Is there cyanosis or not? Is the child doing maximal work of breathing? The presence of drowsiness where the mental state is not intact, and cyanosis, or the child is unable to talk, or the chest is silent, makes me know that this is a life-threatening situation. So by the time you classify the child according to this table, you now go ahead and use the next slide algorithm, the algorithm on the next slide, to manage the child. So the next slide. So the algorithm on the next slide tells us that if the child comes, so I'll pick one of the scenario because we're short of time and I need to run. So if a child has a severe exacerbation, first of all, the child comes, we all know about our ABC of resuscitation, a quick assessment of the child. What kind of exacerbation is this? Is it mild? Is it moderate? Is it severe? You're able to come across severe, or you come across life-threatening. A severe exacerbation, the basic guideline, the basic principle of management is one, because we said that there's airway limitation, airflow limitation, because there's increased secretion, there's constriction of the muscles, and then there's edema. You want to give what we call the relievers. The relievers are the short-acting beta agonists that are going to help you dilate the constricted muscles, and most times we use salbutamol. So you want to give salbutamol, you want to give steroids, which is an anti-inflammatory drug, and then that will help to reduce the edema to an extent. So you want to give that to the child. So the difference we may have with people practicing outside Nigeria is that they may readily have the inhalers available, but we have most of our children coming to us, and we're making the first diagnosis at that presentation, and the child is coming with a severe exacerbation, because our health-seeking behaviors are not the best. So the child comes in, and then you think he has a severe exacerbation. The ideal thing is to use the pressured metered dose inhaler, which most times the children will come with, or they are in the emergency trays. But what we have basically, and most times in our emergency tray in Nigeria here, is the salbutamol nebules, as to be administered as nebules. So never mind, you use that. So what we do is that we give the short-acting beta agonist, depending on the child's age, 4 to 10 puffs over an hour, 20 minutes apart and monitor, and you commence steroids, basically oral steroids. If it is severe, you may want to add ipratropium bromide, or you may want to give parenteral steroids. Monitoring is key. So we monitor the child for response. After monitoring the child, after an hour for response, child response, you assess for possible discharge, and you discharge the child. However, if this child has come with findings in keeping with life-threatening, you have to follow the ABC of resuscitation, commence your oxygen as usual, ensure the airway is patent, breathing and all that, and this child should be managed in the ICU. Most of our patients that come at this stage may not exactly make it, but what we want to bring to the fore and what we want to bring to light is that the Nigerian Thoracic Society has brought out a guideline. It has brought out a guideline for the management of asthma in adults and in children, and we are advocating that doctors, pediatricians, and everybody follow this guideline in the management of asthma in children. So discharge, there's basically no difference with the principle behind discharging the child across globe. I've tried to look at what happens in the UK, and the principle is the same. So I will allow those from the UK to give us the principle. The principle is what should be followed. It's just our habit of not being too good with protocols and guidelines that needs to be corrected. So discharge, next slide, discharge. So discharge, I would not be talking much about this. My other colleagues will talk about it because of want of time. So the next thing I said that we have the acute exacerbation and the stable chronic state where you also classify. Now, the child has come to you with acute exacerbation, you admitted the child, you managed the child briefly for some hours, you discharged the child, or life-threatening, the child survived. You need to classify the child according to the chronic stable. And then you're going to use the long-term control and follow-up, which you assess the child for impairments. Now, the slide that you're seeing now is a table or a figure that shows us how to assess for impairment and risk using daytime and nighttime symptoms. The daytime symptoms, how many symptoms over the night, how many per month, and then is there any limitation, severe, minor limitations? You want to look at the pulmonary function. Well, that may not be always available to us, but we can use the daytime, nighttime symptoms, interference with activity, and exacerbation to classify these children into mild, moderate, severe, persistent, or intermittent. Once you are able to do that, and this comes on while you're following them up, once you're able to do that, you would now place them on medications we call controllers. So in the management of asthma, you need to be conversant with the relievers and the controllers. The controllers are for the second kind of classification of asthma, which is chronic stable state, and the relievers are for the acute exacerbation. In Nigeria here, basically, we prefer to use inhaled corticosteroids. Inhaled corticosteroids for all the various, next slide, please. The inhaled corticosteroids for all the various steps. So once you're able to classify the child, using the algorithm below, you want to place the child on, is it a step 1 management this child needs, which is a PRN, SABA, short-acting beta-2 agonist, or the child is on a step 2, which the child has to be on daily inhaled corticosteroid, or the child will go with step 3, step 4, or step 5. But I think that in Nigeria here, we prefer more of the inhaled corticosteroids. We prefer to use that, but in some other settings, they would antagonists, inhibitors. We don't exactly use it here so much in Nigeria. We prefer it for children who are less than 2 years. Next slide. Next slide. So in conclusion, the Nigerian Thoracic Society has a guideline for management and follow-up care of children and adults with asthma. Awareness of this guideline in the care of children with asthma is highly advocated. We're advocating for it. The first guideline came out 2017. There's a recent review, and the truth is that we're trying to be at par with the globe, with what happens elsewhere all over the country. That's why this guideline is out. We need to improve on our use of guideline. And then also we want to say that there are challenges in the diagnosis and management of asthma in children. like I have pointed out initially, and we need to up our game and see how we can beat that. Thank you very much. These are my references, and then thank you for listening. I hope I didn't overshoot time.
Thank you very much, Dr. Joy Onopepreya, for that brief overview from the Nigerian perspective of managing bronchial asthma. We will come to you with questions. I know right now lots of people are thinking of questions they want to ask, challenges in management. So we will take those questions at the end, like I said in the beginning. We want to quickly move on to have Dr. Akishola Ugudia speak about the United Kingdom management perspective of bronchial asthma. And before he does that, I want to give a brief introduction for Dr. A. Ugudia, MBCHB, PG Cert in Glasgow, MRCPCH, is currently a consultant pediatrician and clinical lead for neonatal unit, St. Mary's Hospital, Isle of Wight. He's also the honorary consultant neonatologist of University Hospital Southampton, Princess Anne Hospital, Southampton, UK. He's currently the lead for pediatric diabetes in St. Mary's Hospital. He's a proud graduate of OAU, and after house job, which is in Elisha, that most OA people can relate to, he had gone on to have his NYSC. He did his residency also in Lagos University Teaching Hospital and bagged a postgraduate certificate in child health from the University of Glasgow in 2016. He completed residency training in Royal College of Pediatrics and Child Health in Liverpool. And he, after previous training in east of Scotland for 3 years. He is an author of several publications and 2 educational modules for the European Society for Pediatric Endocrinology. He has headed the neonatal unit for the last 5 years and counting. And added to that, he is also providing pediatric diabetes service and other responsibilities, including question setting for the examination committee in pediatrics, a national executive committee member of the Association of Children's Diabetes Clinicians, United Kingdom. He also is a level 3 representative for Thames Valley and Wessex Congenital Cardiac Group and principal investigator for 2 trials and many more. He's a provider of advanced resuscitation for newborn infant, a member and contributor to several hospital committees, including blood transfusion, guideline development, and hospital governance group. During his free time, he spent his time with his family. He writes poetry and has an intense interest in the arts. He's also, incidentally, an avid gardener and a very amateur photographer. So please welcome to the stage to speak to us this afternoon, Dr. A. Ogundiya. Thank you.
Now, wow. Tayo, thank you. Don't mind me, guys. So, Joy has already covered most of the important things about this, and I'm quite pleased to see a lot of similarities between what she presented and what I'll be talking about. So my talk is mostly taken from the British Thoracic Society guidelines, which is like the overarching body setting guidelines for asthma and respiratory issues in children. So let me see if this is gonna move. So I have no conflict of interest in this presentation, and I have to put a disclaimer in that I am not a respiratory physician, and these are just pure guidelines from the British Thoracic Society. Although I do some general pediatric clinics and I have some asthma patients, I wouldn't claim to be an expert in pediatric asthma, and I generally just follow the guidance from the national body. And because I do ward cover, I do get children who come in with acute asthma or what has been termed acute exacerbation, which essentially for us falls into only 2 categories. That is acute severe asthma and life-threatening asthma, because we generally don't admit, or I don't come in contact with children with mild asthma most of the time. So the objectives for the talk is 1, to understand the approach to diagnosis and the controversies around it, and 2, to understand the step-ladder approach to non-emergency management. And the outline is just 3 basic headings: diagnosis, clinic management, and emergency management, or management of exacerbations, as it seems. So the diagnosis is The main problem around it is the fact that there's no gold standard diagnostic criteria, which means we can't make any bold, unequivocal statements or evidence-based recommendations into how to make a diagnosis of asthma. And that's the only thing I've referenced there, because if you read the BTS guidelines, the British Thoracic Society guidelines, they are very explicit about the levels of evidence guiding each recommendation that was made based on whether there were systematic reviews or just RCTs or maybe consensus opinion of the specialists in this field. So they've got stratification of evidence, which means everything, the recommendation they made is based on some degree of evidence as it is so far. So the diagnosis is based on the recognition of the characteristic pattern of respiratory symptoms, the signs, and then the test results, which you may get from these things Joy has mentioned, and the absence of any alternative explanation for those symptoms you see. So the factors to consider on initial assessment for the diagnosis include episodic symptoms, which they almost always come with when we see them in the outpatient setting or in the initial contact. Whether they have a wheeze that's been confirmed by a healthcare professional, that may be a doctor, it may be a specialist nurse, or it may be any other person with some healthcare training who can identify a wheeze. Evidence of diurnal variability. Joy did mention daytime symptoms and nighttime symptoms. Whether there's a history of atopy, some sort of allergy in the child or in the family or in the history of the child. And then absence of symptoms and signs that suggest alternative diagnosis like obesity, dysfunctional breathing. COPD, we don't often see in children anyway, but we do see obesity a whole lot. And that oftentimes plays into the same symptoms that we see. Now, there are four main key things that we actually go after in a diagnosis of asthma. And if you have more than one of these, we start to strongly suspect asthma. One of them is a wheeze, which I've mentioned earlier, heard by somebody with training, not just mom and dad saying this child is wheezing. In this part of the world, a lot of the parents use the word wheeze very, very loosely. If a child coughs once, they call it a wheeze. So they come back and say, my baby's wheezing. That doesn't qualify, except you've heard a wheeze, or your registrar has heard a wheeze, or the consultant has heard, somebody with some training has heard a wheeze. Also, breathlessness, which can be quite visible. That's use of increase of accessory muscles of respiration with either a tracheal tug or intercostal recessions, which you can see in the child. Also, chest tightness and variable airflow obstruction, meaning it's not a static picture. It's a picture that can evolve over time that you see. So the UK tried to make it easier for everyone to follow suit, especially those working in the community like general practitioners, health visitors, and other nurses who look after children in the community, into only three categories. One, high probability of asthma when you're assessing, low probability of asthma, and that gray area in between termed intermediate probability of asthma. Now, high probability of asthma include children who have recurrent episodes, who have had a wheeze heard by somebody, and a historical record of variable airflow obstruction. That is, they see the GP today, it's there. Next week, they see the GP, it's not there. And a positive history of atopy, like allergy to something, to house dust mites, to grass, to food, to any sort of atopy. Now, if they don't have any alternative diagnosis to explain all of this, we say this child is a high probability for asthma. And in these cases, we know that if we say this patient is a high probability of asthma, we know he's likely to have asthma. So we then go for a 6-week trial of inhaled corticosteroids according to the British Society. And when we start this, we assess the patient's status with a validated symptom questionnaire, which the doctors keep with them. And then sometimes we do lung function tests. There's the FEV1, like Joy mentioned. Or sometimes they have domiciliary serial peak flows, which they can do at home and then report to the healthcare facility. Also, if they've got an objective and a good response to this treatment, then we say, yes, this is asthma. Because first, we suspected it based on probability. We've offered a trial of treatment and it's worked brilliantly. That confirms it. You know, they say if it barks like a dog and it walks like a dog, it's most likely a dog in this situation. And if the response is now poor in these cases where we had a high probability, then we have to check their technique for the inhalers, whether they're actually using their inhalers, and then you may decide to do further testing at that period in time. Now, for low probability, if you have none of those four things, no wheeze, no breathlessness, no atopy, and no reversibility of symptoms, it's low probability of asthma in that child, and it's not likely you're dealing with asthma. And you should start to explore other options for whatever the child may be presenting with at that time. Now, if there's low probability or you're more likely to have an alternative diagnosis, you then investigate for the alternative diagnosis. Maybe this is a pneumonia presented in this child at this point, or maybe this is the foreign body this child has aspirated despite having just a wheeze and everything. And if you're reconsidering asthma, then you do further testing to see whether you can get a diagnosis of asthma. Now, for the gray area in between where it's not high probability of asthma and it's not low probability, these children have some, but not all. And commonly what we see is they have breathlessness and cough. And they have these two symptoms after the initial structured assessment, or in this case, when we see them, sometimes we offer a trial of treatments, which is usually done in the community by the GPs anyway. If they offer treatment and it doesn't seem to work, then you start to think strongly in another direction. Now, for these children in the intermediate class, spirometry, sometimes you do spirometry pre and post bronchodilator therapy just to see whether you can cause some change in the compliance of the lungs. And that may be enough to help you. In children with intermediate probability of asthma and airway obstruction, where you've identified this through spirometry, you try to do the reversibility tests, or you monitor the initiation of treatment by reviewing them frequently to see if things change. So as you can see, there's no gold standard for diagnosing asthma. We just know about the probability of asthma being the diagnosis, and we offer a trial of treatment. If it works, yay, asthma. If it doesn't, then you have to start thinking twice whether this might be asthma or not. Now, in these children with intermediate probability and normal spirometry results, some of them do spirometry and it's normal, and they're still in the intermediate probability. You then do, mostly we do fraction of exhaled nitric oxide tests in them, where they just breathe into the tube. They look at the number to see, because this test is brilliant at identifying eosinophilic inflammation because it produces nitric oxide in that process. So if they have high nitric oxide with intermediate probability, then we put them straight away into the asthma category, meaning steroids are likely to work for this sort of children because you are dealing with eosinophilic inflammation in them. So, but sometimes the children are too young to comply. Imagine a 2.5-year-old child with symptoms that look like this, and you want them to do an FENO. They can't do that easily. So sometimes we just watch and wait. Like Joyce said, it's hard to make a diagnosis under the age of 5 years. But in the British system now, we're not very prescriptive about that age of 5 years. We're getting kids as early as 13 months being diagnosed as being positive for asthma recently in the country. So sometimes you offer a carefully monitored trial of treatments if the child is symptomatic. Now, this is where it gets tricky. Under the age of 2 years, it's extremely hard because that's the same age where bronchiolitis is rife. It's the same age where some of them can have a viral wheeze that would present like an asthmatic episode. So we try not to label them early, but at the same time, you don't shut the door on the diagnosis of asthma just because the children are really young. Now, this is the diagnostic algorithm I've just gone through for everyone about how to make a diagnosis based on high probability, low probability, or intermediate probability of asthma. And it's essentially saying all of these things I've talked about before. But other things they've mentioned for intermediate probability are things like blood eosinophils. They've got very raised counts. Now, I'll qualify this slightly because I do remember that helminthiasis used to produce lots of eosinophils back in the days. And even if they've got high eosinophils in Lagos, for example, you're not going to automatically ascribe that to the asthma symptoms. You'd have to see whether there are other things that could be giving you that picture. And sometimes we do skin prick tests for IgE, for whatever things we think they are reactive to. They have a skin prick panel, and if they have a reaction, that just confirms the atopy side of the history, which might help you swing into high probability or push you back into low probability of asthma. Now, when we see them at first, or when the GP sees them at first, there are some things that must be certain, like you need to refer these children for higher level of care to the hospital, or as in the case of Ife, it might be the teaching hospital. If you're working in a private hospital, or if you're working in Lagos, these kids have to go to LASUT or to go to LUTH, any other tertiary center. If your diagnosis is still unclear, these are not the children you want to sit on in a private hospital if you are privately practicing somewhere. Because if it's unclear, what makes you think this is not primary ciliary dyskinesia? What is, I know cystic fibrosis is not common in Nigeria, but what if this is cystic fibrosis we are practicing somewhere else? What if this is chronic inhalatory kind of inflammation in the lungs? It is difficult to know. If the diagnosis is not clear, don't sit on the children, because asthma, as you've heard from the first teaching, can be a really dangerous condition. If they've got poor response to monitored initiation, you've tried them on treatment and it's not working, please refer them onwards. If a child has had a severe or life-threatening attack, even I wouldn't sit on them. I send them to the asthma specialist, because these are the children that could go off at the drop of a hat. And the last thing you want is to start having an inquest or a coroner's inquest because you missed severe asthma in a child or you didn't manage the post-admission care properly. Also, if the patients or the parents are anxious, I often just refer them, because frankly, you don't want to sit down on those kind of patients. You are never going to really allay their fear until they've seen a specialist in their condition. So if you're seeing them in a private hospital in Lagos, please send this kind of children to Luth, just to make sure as a doctor you're covering all your bases. Other things to think about for alternative diagnosis: if you have a little child who is failing to thrive, it's extremely unlikely in asthma that they fail to thrive just because of the asthma. There might be other things going on. I've had a child before with a ring, a trachea ring, that this child had aortic notching, that such to the point where the child had airway obstruction, had features that looked like asthma, but wasn't exactly asthma, but the child wasn't failing to thrive, and that was the key giveaway in this situation. Unexplained findings, focal signs. If you have a wheeze that's fixed on just one side, check whether this child has inhaled a groundnut or a corn or something recently, and that might not just be asthma. If they've got stridor, asthma classically has a wheeze, not a stridor. It's not an upper airway problem. You shouldn't have stridor with asthma. So if they have stridor, think of alternative diagnosis. Abnormal voice or cry, like I said, from that kind of a trachea ring around the trachea, what do I call it, a vascular ring around the trachea, that can give you that kind of a picture. If they've got dysphagia or problems swallowing, there are other things going on. It's not asthma. If they've had symptoms from birth, or they had perinatal lung problems, a child with lots of cysts in the lungs at birth, this is not asthma you're dealing with a different condition. If they have excessive vomiting or positing with features like this, it's not asthma. If they've got severe upper respiratory tract infection, it's probably not just asthma, because asthma is a lower respiratory tract issue from the diagram you saw earlier. If they have a cough that's persistently wet or productive, it's probably not asthma. Family history of unusual chest disease, if they've got nasal polyps, or if the patient and the parents are just anxious, just consider alternative diagnosis, because sometimes the parents are usually right. If they keep coming back, there might be a reason why they keep coming back. So when we see them in the clinic, we just follow the step ladder approach. And I'm quite pleased Joy had practically the same picture as a step ladder approach. And the aim is, as she said earlier, no daytime symptoms. You want them to be free of symptoms in daytime. Not waking at night due to symptoms of asthma, no need for rescue medication, no asthma attacks. If you can achieve all of this, you would have completely taken care of that child's asthma. And you want them to have minimal side effects of medication, which Joy did also mention. So we start the treatment at the level most appropriate to the initial severity. So if the child is coming in really severe, you're not going to start at the bottom of the ladder. You're going to where that child is to start from. And the aim is to achieve early control. And then once you achieve control, you have to maintain that control by going up and down the ladder as necessary. And when the control is good, you can back down the ladder. And oftentimes we see them every 3 months. This is an identical picture to what Joy presented earlier, where this is the stage where you're still, if you can see my cursor, you're still trying to make a diagnosis at this point. And you can try a 6-week course to see whether anything changes. But once you've made a diagnosis of asthma, the first thing is, now we call it a reliever and preventer, just to differentiate the two groups of drugs. The preventer is what prevents the exacerbations. The reliever is what gives immediate relief to the child. That's salbutamol that we commonly use as inhalers. And one of the important things here is that it's always safe to use a spacer for the child, especially because all the research doesn't show any difference between either inhaling straight into the mouth or inhaling through a spacer or a volumetric device, whichever one you're using for that baby. So our first regular preventer is low-dose inhaled corticosteroids, that's ICS. Or for children under 5, we often start them on leukotriene receptor antagonists, that's montelukast is the common one we use here. Now, next level is whether they are over 5 or under 5. If they are under 5 and you started them on leukotriene receptor antagonists, the next thing you'd go for is the corticosteroids. Now, if they're over 5, we just go for the long-acting beta antagonist. That's the LABA that you go on to. And then you move up and down the ladder. But the interesting thing about the UK is for the level of care, once you've gotten to this third rung of the ladder, if things are not working, they have to go into like quaternary level care, to go into the respiratory pediatrician, the specialist who can do bronchoscopy, look into the lungs and see everything. So if you've started a child anywhere in the world on steroids and it doesn't seem to be working, at that point, you start to think of whether you need to refer that child onwards. Now, for those ones that are not in the clinic, like the exacerbation Joy mentioned earlier, if they're mild exacerbation where they can just use 2 to 4 puffs of inhaler, we don't worry about them. I don't even see them because they are sorted out by GPs or the nurses in the community. If they come to the hospital, it's because their saturations are less than 92%. Once that happens, they fall into severe asthma category, and it could end up being life-threatening if their peak flow is less than 33%, or they have any of these other symptoms. Now, for guys just starting out, be wary of a silent chest. You can't hear a wheeze, doesn't mean the asthma is better. If you can't hear a wheeze and the child still looks ill, be very scared. That child is close to death. And that's the point where you should be pulling the emergency buzzer, screaming your head off, asking for all the help in the world. The management of this stage is, if I remember how we were taught in IFA in those days that we can't ever forget, is SOS, save our souls. Salbutamol, oxygen, and steroids. Those are the 3 planks of it. When they walk in through the door and they can't breathe, slap on the oxygen, and that usually helps. Now, this is a busy slide, but this is my part of the UK. This is the guideline we use for, we like everything in steps in the UK, just for people who don't like to read. For severe asthma, you start from step 1, which is 15 liters of oxygen via a non-rebreathing mask. And you give back-to-back salbutamol nebulizers, which is, like Joy explained, every 20 minutes. And we give 3 of those. But once we put you in the severe category, we always give proton bromide nebulizers with it. We mix it together, mix nebs, give 3 back-to-back, and you give oral prednisolone. And if they're really bad or life-threatening, you are giving IV hydrocortisone at that point in time. Now, the only one we've added into it, which works brilliantly from all my experiences, if they haven't responded to that, because by the time you've done that, it's 40 minutes gone already down your management pathway, because when they come in, the nurses will start a clock for you. Everything must be done to time. This is a life-threatening emergency. The next thing is we're banging straight with IV magnesium bolus. And that honestly works like magic. Every time I've seen it, I'm always amazed at how it works. If it doesn't work, you are in for serious trouble. And that's the child, you should be ringing the ICU saying, I think I'm going to need a bed because magnesium hasn't worked for this child. They're needing loads of oxygen. And at that point, you notice that we haven't given any salbutamol IV previously. If that hasn't worked, we bang on with the IV salbutamol. And then we start it as a bolus. Then we start it as an infusion. And then if it's not working, we add aminophylline to it. Sometimes they're on like 6, 7 different infusions per time. But you have to be mindful of doing blood gases when this is going on, because if the CO2 starts to rise for a child, in fact, if you have normal CO2 for a severe asthmatic, you should be calling for help because that child needs ventilation. We all know what happens in asthma, that because they are hyperventilated, they often have low CO2. If a child has CO2 of like 5, which is normal range, and the child is severely breathless, be very worried because that child is already retaining CO2. And that means this child is going to go into respiratory failure extremely quickly. And you might have a cardiac arrest on your hand if you're not careful. And so there are indications for doing chest x-ray. There are high-risk clinical signs that you should be shouting for help and screaming. If in air they have SAT less than 92, if oxygen partial pressure is less than 8, if they have normal CO2 over 4.6, that is a child who is trying to die on your watch. Now, you mind out for salbutamol toxicity because every time you do the blood gas, oftentimes you have raised lactates, and that's because you have metabolic acidosis, which often follows excess salbutamol. And sometimes that itself drives the work of breathing because they are breathing really hard, trying to get rid of the acidosis, the metabolic acidosis. And if all of this isn't working, you have impending cardiac arrest. At that point, they should be intubated and the child should be put on the ventilator very quickly. This is a stage we don't get to often, thankfully, but when we get to this stage, it's a 50-50 chance. Once you ventilate a child with asthma, getting them off the ventilator, anybody who has been in ICU will tell you is a Herculean task because you never know which way things are going to go at that point. So I hope this has just explained a bit about what we do for either the stable asthmas in clinic and then the unwell ones who come into the hospital. And when they are being discharged, each person must have a written WHEEZ plan with their name on top. I've got examples if you wanted to see them. They've got their name written on top. This is the WHEEZ plan. They have a copy. The school keeps a copy. The GP keeps a copy. The parents keep a copy. So wherever this child goes, somebody knows what to do. If the child says, I'm feeling breathless or my chest is tight. They have a personal management plan. You assess for what triggers around them. Commonly, it's parental smoking because the kids don't smoke. But if people smoke around them, then of course they are exposed to the cigarette smoke, which can trigger off the reactions in the lungs. Then we train the family in what to do. Everybody looking after that child must know what to do for asthma. And then ongoing clinic follow-up with either the general practitioner or the asthma nurse. In fact, GPs would always write to every family with asthma to come in for an asthma review at least once every year. And then if they're required, you send them to a tertiary specialist. But it's important to remember that asthma can be readily life-threatening, and only good management would ensure good quality of life and survival. To summarize, diagnosis is mostly clinical. A stratified approach helps in tailoring the care for the children. Good assessment and follow-up is essential. And acute management when they're in hospital is an emergency. You cannot waste any time, because if you waste time, you might end up with a sicker child than you bargained for. Thank you. We'll take the questions together afterwards.
Thank you very much, Dr. Akinshola Gudia, for that full expository of managing asthma. And I know that it's already 4 p.m. It's almost 4 p.m. Eastern time, 4 minutes to 4. Usually we have this program for an hour, but this is a lot of information and good information. We already have people asking for the slides. We will have that posted. And if you provide your email, we will try to get that to you. But more importantly, this is a recorded Zoom meeting, and therefore it will be provided on YouTube for you to listen again, go over the slides. You can pause and rewind. And more importantly, you can subscribe so that you get alerts when other information is posted or further discussion is being made on that particular portal. So take the opportunity to follow OU Med Talks on YouTube. Click and subscribe and like, and go back and review the slides again. Now we will move on to have Dr. Andrew Faniku speak to us this afternoon. And please, if you wouldn't mind, give him a few minutes. He will be speaking about the perspective of bronchial asthma management from the US angle, and providing us information or maybe differences, things that he has witnessed from his own experience. And to introduce Dr. Andrew Faniku, he's a pediatric hospitalist at the Advent Health Hospital in Killeen, Texas, BSW Health. He also graduated from Obafemi Awolowo University in 2005 set. He had his pediatric residency at Texas Tech University Health in Amarillo. He also studied computer information systems in Oakland, California. And he has community experience working as a general pediatrician in Valverde Hospital he had worked in Nigeria prior to now in Ado Ekiti. So he's well versed in managing pediatrics. From his experience, he is a medical examiner, Porter Medic, California. He is a member of the Texas Medical Board, DEA, DPS, BLS, PALS, NRP. He has an ECFMG certificate. He's had several professional awards and honors, including 2013 Provider of the Year of United Medical Centers in Del Rio, Texas, first place annual student and resident research day. He has written several publications. He's still a committee member of Maternal Child Health Committee, a PREP audio resident panel. He has had several publications. I can go on. In the interest of time, I would like to say he's a family man who enjoys salsa dancing, acrylic and pastel painting, and he's a creative writer. So look out for his book, which he will let us know when it will come. So welcome onto this platform, Dr. Andrew Faniku. You're sharing your screen. Please go ahead with your presentation. Thank you.
Thank you for the introduction. My head is swelling and it might burst before the end of this. Can you hear me?
Yes.
Okay.
Very well.
Okay. Yeah, I'm really honored to be part of this. Unfortunately, my computer, my desktop, which is the new one, doesn't have a camera. So I'm having to use my phone as well as the computer, and I'm logged on both places. Can you see the slides?
Not yet.
Not yet. It's a blank screen.
It's a blank screen. Let me see if I can share it through the computer. But yes. I don't want. Can you see this?
It's better to share the whole screen, not just the presentation, if you can do that.
Okay.
Thank you.
Okay. That means I'll have to connect off the phone and then use the computer's audio, and that way.
Sure.
Okay. Let me just connect to the phone back to me. Leave.
And while we're having Dr. Andrew Faniku situate the technology and make sure that everything's working well, let's give opportunities for Dr. Ogundiya and Dr. Joy to answer like 2 questions that I have had. And while Dr. Andrew is trying to connect to the audio, let's give him a minute. Both of you have talked about the prevalence of childhood asthma. And I wanted to ask a general question, which maybe most doctors wouldn't ask. But one question that regular people who watch this video later on might ask is, how can I reduce my risk of asthma? Are there foods I should give my family, my children to avoid? They say it's genetic, yes. What are the tests that I can do to know the triggers for this child's asthma? There are moms here, there are sisters here. So what do you think? What are your responses to that? Can we have Dr. Joy, then Dr. Ogundiya speak?
Yeah.
Okay. So I'll speak before Ogundiya, right?
Yes.
Okay. Sure. So basically, are there ways to reduce the risk? Yes, there are triggers. So most, like from the pathophysiology, I said that the triggers come in and then they set in a cascade of reaction, inflammation, then you have constriction and secretion, mucus secretion. So if you avoid the triggers, you're going to likely prevent exacerbations. You're going to likely prevent presentation in the hospital. So triggers, indoor and outdoor pollution, environmental pollution, smoke, dust, mites, mittens, and then you have poultry, animals, furs, and then are also triggers. Then obesity, one could actually cut down on weight. It's also been found to be a risk factor for asthma. And then atopy, that's family predisposition to developing eczema. And that, well, you may not exactly be able to do anything about that because it's most likely genetic, and you could only prevent exacerbations by ensuring that that other triggers are avoided, and then you're on your controllers. Okay, like Alaba said they call it preventers, we call it controllers. So the controllers are supposed to help you prevent exacerbations and hospital visits. So your second question was about other tests, right? So, okay,
Yeah.
so there are some tests, like the ones that I know are readily available here, and tests like, okay, Alaba talked about acidophil. I didn't go into that. So you could check, you could do the IgE, you could check eosinophils from the full blood count, and you could do the atopy test, to do skin pricking test to find out what are the likely allergens that a child might be reacting to. In some cases, you may not exactly find the allergens, so you may not exactly be able to prevent exposure to such allergens. But in several cases, in so many cases, the child could actually say that, oh, that I cough more when they're sweeping, or when I do strenuous exercises, or when I'm exposed to cold or too hot weather, or when I'm playing with my doll or something like that. So in that case, you identify triggers, and then you can actually prevent exacerbations.
Yeah.
So Alaba, over to you.
There's not much else for me to say. Joy has mostly covered everything, because it's essentially avoiding the triggers. That's the only way. I mean, the BTS guideline was actually good enough to include what we call primary prevention, secondary prevention. And if you don't mind, I can quickly share that while my colleague is getting ready with his own presentation.
Yes, please go ahead.
It might be sharing my whole screen. Let me see if I can find it. If I can find it somewhere. Yeah. So it's this is the BTS page, which actually goes through prevention. So, and this alphabet on the side, if you look at the BTS guideline, tells you the level of evidence. And essentially, it's measures to reduce in utero or early life exposure to single aeroallergens, so that house dust mites or pets or single. It's not recommended for primary prevention because it's not been proven to help. That's evidence A. For children at risk of developing asthma, complex, multifaceted interventions targeting multiple allergens may be considered in families who are able to meet the cost. That's if they have the money for it. And in the absence of any evidence of benefits and the potential for adverse effects, telling the mom to avoid any kind of food during pregnancy or lactation is not recommended, because it's not been shown to prevent the incidence or the prevalence of asthma. There's also insufficient evidence to make a recommendation regarding maternal dietary supplementation in pregnancy or use of probiotics in pregnancy. Breastfeeding should be encouraged. This is one of the few things we have some level of evidence for, but it's a C-level evidence. Note it. A is the highest level of evidence you can have in this situation. Breastfeeding should be encouraged because there's a potential protective effects in relationship to early asthma. So children who are breastfed, who have 6 months exclusive breastfeeding, are less likely to show asthma earlier on. So we encourage breastfeeding for one of those reasons. If a child is obese or overweight, you can tell them to drop weight or help them to plan weight loss. And current or prospective parents should be advised on many adverse effects, especially smoking. Smoking of any type should be avoided in pregnancy or around the family. Now, secondary prevention, spraying chemicals around your house to get rid of house dust mites is not essential. But if you can vacuum things and things like that, yes, that can work, but spraying things is not recommended. People with asthma should be advised about the dangers of smoking and secondhand exposure. That's them not even smoking, but someone in the environment smoking. Weight loss also works for secondary prevention. Air ionizers, all kinds of devices people sell and say, oh, put this in your house, it cleans the air and everything. Nope, it doesn't really work. There's no evidence for it. Breathing exercises, not very helpful. So in all of this, the BTS has actually covered some of the things that may help prevalence of asthma, but generally it is avoiding the triggers. If it's grass, when they're cutting grass, avoid that. If it's exercise induced, there are ways of managing that. They can speak to the doctor about managing exercise induced asthma. Thank you.
Thank you very much, Dr. Ogundiya. You did answer that question, and Dr. Joy Onopapreya, thank you so much for answering those questions. We can move it back to Dr. Andrew Faniku. Are you ready for us now? I believe you're unmuted, yes. So we can hear you if you speak. We're still having some connection issues for Dr. Fanico. Yes, I believe we can hear you now, Dr. Fanico. Okay, we're about to see something. We see a bar. It's that, if that's you, could you please expand it and let's see what is on your screen? All right. I see that screen sharing is not seeming to work for Dr. Fanico. If you can hear us, Dr. Fanico, could you please just let us know, and you can probably go over your presentation and send in the slides. We can have that posted as well. Can you hear us? I'm not sure that Dr. Fanico can hear us. So I will move on to another question, and that's about management. Regarding action plans and management. Most of the time, physicians will give an action plan for the child, and one of the questions that comes from that is, if a child has an action plan, is that child meant to personally know the action plan, or what age is the limit when they should know it or not know it? Are they supposed to take it to school? Should they let their physical educators know? Is it something to check in the institutions that they're in, that they can manage bronchial asthma? You know, we have seen in practical situations where somebody had an asthmatic attack in traffic, right? Couldn't get an inhaler. What are those emergency things that they can do at that point in time? Or, you know, what are the checks and balances, especially in management of acute asthma? And please put it in perspective of the countries you're in. United States, you might say call 911, right? Paramedics will be at your door in a few minutes, right? Let's apply that to our regional perspective and you know, really operationalize management of bronchial asthma in a few minutes. Do you want to start, Dr. Wudia? Should I make Dr. Nopepeya start?
No, I'm fine.
Okay.
Action plans are, the child, as much as possible, if they have an age to understand, should know what their asthma action plan is. It might be something like, when you feel your chest is tight, take 2 puffs of salbutamol and watch for the next 1 hour. If things are not better, take an extra 2 puffs. If that doesn't work, ring the doctor, or ring, in the UK, we ring 111 for things that doesn't really need an ambulance immediately. Somebody would advise you on the next steps to take. So the child is supposed to be aware of it if they have an age where they should be aware of it. And it's not age prescriptive. It's more of the child's developmental status prescriptive. Also, schools should be aware of children with medical problems, because if they've got an action plan to take this many puffs when they feel this way, then the school should have an action plan copy with them, and even a prescription for the school where they keep a sample of the inhalers in school, or with this and that, so that the teacher knows that if this child says, Mrs. XYZ, I can't breathe properly, they go into an office, they look at the plan, they bring out the medication that is already kept in school with the child's name labeled on it, and they do the first steps. And if that doesn't work, school will ring the parents and ring for an ambulance at the same time, and they meet up somewhere. So that's just the way it works around here. Joy?
Okay, so thank you very much, Dr. Gundia. I guess you all know we don't have any number to call. We don't have any number to call in Nigeria, but basically what we do, like when I was in Lutz, they have it's like the action plan is written like a diary, an exercise book which we give to the child. Now most times GSK collaborates with us, and then they give us a lot of things, and they give us drugs, they give us like a short action plan, which is well written out for children who can read, and they can actually read it. So when they come to clinic, we have an asthma clinic. When they come to clinic, what we do is, for those who are adolescents, most especially, we try to explain to them how to use the inhaler, and then how many times to use the inhaler, when they feel that. And then by the time you've done it 4 times and the symptoms still persist, we advise them to come over to the hospital. But where we have the challenge is we don't readily have spacer device available. So we improvise. In some settings, we have to improvise and give them spacers, which their parents are expected to actually carry along with the children, especially those who are basically less than 7, 8, who are not exactly well able to administer the drugs by themselves. So we actually do the written action plan thing, and GSK helps us with, has helped us with a short written action plan, and then we have our asthma diaries in quote where we exactly, but we don't have anywhere to call, we don't have any number to call. We just walk by faith and say, okay, if the child is above 8 years, okay, the child walks around with his inhaler in his bag, and then when they're going to school, the mom puts it in. Right now, we have some schools that are really advanced. So in such schools, they tell the schools have a matron, they have a sick bay where the children, like in my children's school, they have a sick bay. You just make sure that you acquaint yourself with whoever the matron is, and then you tell her that, oh, my child may need these medications, but it's always in the child's bag. So there are some developed schools that you could have such practices available and for the children, but majority of our schools don't have anything like school who to call, what to do, or nothing. Nothing. Even some of the big schools do not actually have, they do not actually have how to cater for children when they come down with exacerbations or not even asthma, any condition. We're hoping that we'll get there soon, but actually when you come to standard tertiary hospitals, there are action plans for the children. Thank you.
Thank you very much, both. And now we have Dr. Andrew Faniku live with us. Finally, here we go. So, Dr. Faniku, over to you. I'm going to ask you to unmute, please.
Yes, thank you so much. And I don't know if you can see my screen. I have a version of asthma action plan that we use, and we usually would give them when they come to the clinic. And the green zone is you're doing well. Yellow zone is when you start to have symptoms, and red zone is when you need to call the emergency. And most of what we do is also similar to what they do in Europe, like Dr. Alaba stressed. The other things that we emphasize is the spacers and in the clinic. And I'm trying to see if I can share that screen with you so that you see what the kind of spacers we use on, and I'm using my phone here. So this is what the spacers we use based on the child's, can you see, based on the child's age?
Yes.
Sometimes we use the spacers medium, small, and large, and we use the small size spacer for 0 to 18 months, medium size 1 to 5, and greater than 5, you don't have to use a face mask with the spacer. But most of what they do in United Kingdom is also what we do here in the US. And unfortunately, I wasn't able to access my slides on the computer and do the Zoom meeting at the same time. But most of what you do in the UK is what we do here, using the short-acting beta agonist for rescue. The other things are just semantics. We call it rescue inhaler, and then we use the inhaled corticosteroids as controller. We call it controller meds, but I remember you gave it a different name.
Preventers.
Preventers, we call it controllers. And then we have the 3 categories: the intermittent. If you're having less than 2 symptoms per week, then we don't give you inhaled corticosteroids. And if you're having more than 2 symptoms per week, then we call it persistent. And then we grade it based on severity into mild, moderate, and severe. And based on that, the dosage of the inhaled corticosteroids. So basically what you said earlier is the same things that we do in the US. Just more emphasis on using spacers. And the other thing, we use HFAs because we don't use powdered inhalers. We use the aerosol inhalers. And a lot of people, because of easy access, they use nebulized treatments even when they're less than 5. And they can still use the spacer, but a lot of people have nebulized treatments because it's cheap. It's cheap enough for most families who have asthma to have it at home.
That's interesting.
Right. So the focus, because of our time, was for Dr. Faniku to tell us about the differences, similarities between the management of asthma in the different regions. And it brought to mind a question as we're aiming to round up, that when is it indicated that a patient should be given epinephrine? That injectable, right? That's epinephrine. Am I right? They call it EpiPen. Am I right?
Yes.
Oh, okay.
In asthma, in asthma.
Asthma. I have seen an asthmatic patient being given EpiPen to carry around. Why? Is that because there are other allergies, or is there something else? What causes a physician to prescribe that? Is it routine?
No.
So in the US, we would usually give EpiPens for severe allergic reactions to, say, food allergies or seafood allergies, not so much for asthma. That's just the practice, not so much for asthma, unless they have other allergies that will cause them to have anaphylaxis.
Yeah.
Okay.
I totally agree with that. We only prescribe EpiPen for anaphylaxis, and it's not even every not every allergy that will qualify for an EpiPen and adrenaline auto-injectors or anything. They wouldn't, because the last thing you want is for somebody to stab a child with adrenaline. For a child who might have some reactions to it, you can go into SVTs. You don't want to do that in the community for a child. So we only give it for anaphylaxis. And even then, once they stab it in, they have to ring 999 for an ambulance to come immediately. So it's not part of asthma management at all. No.
That probably speaks to the fact that that patient not only has asthma, but has other allergies that are being managed.
Yeah.
And therefore, they can be given both of them, both the asthma management and then the other allergies, right?
Yeah, yeah.
Okay. And you mentioned tests before. Aside that, for the general treatment or the general ailments where they do testing, skin testing, is there anything like that for asthma?
Joy, I'll let Joy take that one.
So skin text, that because we know that allergy is a major it plays a major role in asthma, because it's part of the risk factors that a child has atopy, there are genetic predispositions to asthma. So skin testing it's part of the test for atopy to identify triggers. So when you do the skin testing, it's just say, okay, what are the likely what's allergen? What is it that this child is probably reacting to? So skin testing is actually part of the other tests, and those tests come in when you just like Anaba agreed that we do not have specific. It's not like you say, okay, if you see blast cells, you think you're talking about leukemia, or if you do a bone marrow and you see percentage of blast, blah, blah, blah. We don't have exact definitive diagnostic tests for asthma. You just have tests that are indicative of possible asthma. So if you are lost for perfect diagnosis, a definitive diagnosis, you could do that to say, okay, this may just be allergy and not just full-blown asthma. So skin testing is actually part of the other tests.
Thank you, everyone. We have extended our time today, and I hope that it has been helpful, very helpful for you to listen into these great speakers. We do know that anybody that has provided their emails, we will try to share the slides as long as we get proprietary permission from the others to share that. And otherwise, you'll be able to look at it on the online portals on YouTube. So please go on there. This recording will be shared there shortly. And we'll look forward to you joining us again on another episode. We want to make this more interesting, more applicable to practical clinical practice across the regions. So thank you very much for joining us. I'm your able host. I am Tayo Adebayo Awuyale. Thank you so much and have a rest of your afternoon. Thank you. Bye.
Thank you so much, able host.
Evening for those.
Thank you, speakers. Appreciate you.
Bye.
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 Bye.